My name is Dr. Arif and I'm your tutor for today. On this channel, we simplify medical knowledge from surgery, medicine, ops, gynecology, obstetric, and related specialities so that learning medicine becomes easy and approachable for everyone. With that said, let's jump to today's session of clinical anesthesiology and pain management. The learning objectives of today's session are pre-operative evaluation. Underneath, we will study about identification of key risk factors, pulmonary evaluation, pre-operative lab tests, prevention of Mendelson syndrome, which is severe chemical pneumonitis, reduction of difficult intubation. And then we will study and learn about complications and their management during the surgery, which are life-threatening, like laryngospasm, bronchospasm, complications associated with anesthetic agents, post-operative immediate complications, and post-operative delayed complications. Now let's jump to pre-operative evaluation. The first thing that the anesthetist has to do is to identify key risk factors such as age. Risk associated with age is due to comorbid conditions like malnutrition, frailty. Elderly patients are generally weak and delicate, and age-related cognitive and functional impairment. Second risk factor that the anesthetist should look for is exercise capacity. Those with good exercise tolerance has low risk, such as they have the ability to climb up stairs, heel, and perform heavy works. And those with poor exercise tolerance has high risk of cardiovascular and pulmonary complications. And the third most important key risk factor, which can be identified from patient's history, is family history of anesthesia complication, such as malignant hyperthermia and succinylmethonium apnea. We will discuss about them in details in coming lectures. The second thing that you have to do in pre-operative evaluation is pulmonary evaluation. In the history of the patient, check for dyspnea, cough, exercise intolerance, and some key risk factors associated like age above 65 years, smoking, COPD and asthma, low serum albumin. Low serum albumin is important because it may lead to pulmonary edema. Obstructive sleep apnea because may lead to hypoxemia and respiratory failure. Pulmonary hypertension and interstitial lung disease. In the interstitial lung disease, the lungs do not expand, and due to which the tidal volume will be reduced, and this leads to hypoxia. Then when you find those risk factors or some of the symptoms, then you have to make plans and strategies to reduce pulmonary complications. Number one, you have to ask the patient for the inspiratory muscle training with incentive spirometry. As you see in the image, the guy is holding the incentive spirometry in his hand and he is practicing and training his inspiratory muscles. Second, that you have to avoid pain curonium because it has a long duration of action. Third thing, before surgery and before induction of anesthesia for some weeks, the patient has to take multiple sessions of chest physiotherapy, and you can give continuous positive airway pressure. Now there is a brief differences between CPAP and BiPAP. CPAP stands for continuous positive pressure, and there is single constant pressure level, and only there is one pressure setting for both inhalation and exhalation. While BiPAP stands for bi-level positive airway pressure, there are two pressure levels, and higher pressure for inhalation and lower pressure for exhalation. Now, the third thing that you have to do is some important pre-operative lab tests like CBC, complete blood count. Look at hematocrit, hemoglobin level, and platelet counts. Then coagulation profiles such as PT-INR and APTT, renal function test, and liver function test. These two tests are important because we need the kidneys and liver to be functional. Fourth thing, prevent aspiration pneumonia, and chemical pneumonitis is also called Mendelson syndrome, which is caused because of aspiration. And there is a side note that pregnancy of greater than 12 weeks is always considered full stomach. So what are your plans? First, aspiration prophylaxis like using antacid, for example syrup sucralfate, or you giving H2 antagonist like tablet fumatidine, or you can give prokinetic agent like tablet itopride, which is 50 mg given before meals. Second thing that you have to do is that you should put the patient on NPO, that is nil per hour. So for clear liquid, NPO of 2 hours before surgery; for breast milk, NPO of 4 hours before surgery; for infant and for infant formula and light meal, NPO of 6 hours before surgery; and for heavy meal, NPO of 8 hours before surgery. Then perform Selick maneuver during induction of anesthesia. What is Selick maneuver? Pressure is applied to cricoid cartilage to occlude upper end of esophagus at the time of induction of anesthesia. But remember, you should not mix it with burp maneuver. Burp maneuver is used to make vocal cord to become visible during the passing of endotracheal tube. So how it is: burp stands for B for backward, U for upward, R for rightward, and P pressure on thyroid cartilage. So when you are passing the endotracheal tube and vocal cord is not visible, you ask the operation theater assistant to apply backward, upward, and rightward pressure on thyroid cartilage. This is called burp maneuver, and that was Selick maneuver to prevent regurgitation of gastric content, so that to prevent Mendelson syndrome or aspiration pneumonia. Fifth thing that you have to do preoperatively is pre-duct difficult intubation. We have a mnemonic of 4 M's. The first M stands for thyromental distance. This distance is from thyroid notch to mentum, and it should be greater than 6.5 centimeter. And the second thing that you have to measure is sternomental distance, and it is measured from sternal notch to mentum, and it should be greater than 12.5 centimeter. As you see in the image, an illustrative explanation of the thyromental distance and sternomental distance. Second M stands for Mellem-Petit. Mellem-Petit means the measurement of amount of space in patient's oral cavity. Look at 4 structures: hard palate, soft palate, uvula, and pillars. Pillars are palatoglossal fold, which is present anteriorly, and palatopharyngeal fold, which is present posteriorly, and in between them there are tonsils. So mnemonic is push: P for pillars, U for uvula, S for soft palate, and H for hard palate. As you see in the image, the class 1 is that all 4 structures are visible. It is push. In class 2, there are only 3 structures are visible: uvula, soft palate, and hard palate, and pillars are not visible. While in class 3, soft palate and hard palate are only visible, while in class 4, only hard palate is visible. So in class 4, it is very difficult to pass endotracheal tube. So you can just remember it by push, ush, ha. So the third M stands for measurement of movement of neck. So movement of neck, you ask the patient to do flexion, extension, and rotation of the neck. If the neck has full range of movement, so patient is fit for anesthesia, and there won't be any difficulty while passing endotracheal tube. The fourth M stands for craniofacial abnormalities, such as malformation of skull. Example is hydrocephalus, means the quantity of CSF in the spinal canal and in the ventricles of the brain are too much. And microcephalus means small skull. Micrognathia and macrognathia. Micrognathia means that the mandible or lower jaw is small, while macrognathia means that the mandible or lower jaw is large. Then you have to look at the teeth. It can be back teeth, as you see in the image, protruded teeth, or loose teeth. They will create problem and you will be in trouble while passing the endotracheal tube. Fourth thing that you have to see is any obstruction in the neck, may be caused by obesity, swelling around the neck, or hair such as goiter or bull neck. Then there are some craniofacial abnormalities associated with syndromes like Tricher-Collins syndrome, Goldenhar syndrome, and Pierre-Robin syndrome. So far we talked about these. Let's jump to ASA physical status. American Society of Anesthesiologists has created ASA physical status classification system for preoperative evaluation. In class 1, healthy patient, no systemic disease. In class 2, there is mild systemic disease, but there is no functional limitation like controlled diabetes mellitus, controlled hypertension, and obesity. In class 3, there is severe systemic disease with functional limitation. Functional limitation means, for instance, patient rests after 2 flights of stairs. Example of class 3 is stable angina and COPD. Class 4, severe systemic disease that's constant threat to life. Example is unstable angina, liver, heart, and kidney failures. In class 5, moribund patient not expected to survive without operation more than 24 hours. For example, is a ruptured aortic aneurysm. And class 6, brain dead. There is plan for organ donation. Now, if surgery is emergency, then E is added to ASA class. For example, if it is class 3 and surgery is emergency, for example, acute abdomen, then along with class 3, you add E. Now let's learn about some important and life-threatening complications that can occur during surgery and along with their management. First one is laryngospasm. Patient has stridor. Now how you're going to identify that the patient is having laryngospasm is that the patient is having inspiratory stridor. If there is partial occlusion of airway, but if there is complete occlusion of the airway, then there will be silent chest on auscultation because there is no air entry. So first and foremost is that you have to call for help, during which you have to give 100% supplemental oxygen with EMBO bag mask. EMBO stands for Artificial Manual Breathing Unit. You can give continuous positive airway pressure, perform jaw thrust, which is also called Laron's maneuver. Jaw thrust is performed to prevent the backfall of the tongue, which may block the airway. Now, time is that you have to break the laryngospasm. It can be done by giving intravenous propofol at the dose of 0.5 to 1 milligram per kg. Alternatively, you can give sevoflurane or isoflurane. If still the laryngospasm does not break, then give succinylcholine at the dose of 0.5 to 1 milligram per kg IV, or you can give intramuscular at the dose of 4 milligram per kg. Now, to prevent bradycardia, especially in children, you can add atropine at the dose of 0.2 milligram per kg. Second life-threatening situation is bronchospasm. It is the constriction of bronchial smooth muscle, and how do you identify is that the patient has expiratory wheeze. This is caused when endotracheal tube touches carina. Carina is the point where the trachea divides into primary bronchi, or patient is on beta blocker, or any foreign object has entered into the airway, or there is aspiration, or patient has allergy or asthma. First thing that you have to do is call for help, and during which you have to give 100% oxygen with manual ventilation. Remember that there is a slight difference in the management of bronchospasm and laryngospasm. Here you give manual ventilation with slow respiratory rate and prolonged expiratory time and small tidal volume to avoid barotrauma. I want to repeat it again because it is important that you have to give 100% oxygen. You should keep the respiratory rate slow, and the inspiration time should be less and expiratory time should be prolonged, and try to keep the tidal volume, which is normally 400 to 500 ml of air, it should be reduced. All these things are done to prevent barotrauma. Then you have to break the bronchospasm by giving intravenous propofol at the dose of 0.5 to 1 milligram per kg. Alternatively, you can give sevoflurane and isoflurane. Even after giving propofol, still the bronchospasm doesn't break, then you add bronchodilator. The first line of bronchodilator is short-acting beta agonist like salbutamol. 4 to 8 puffs are given by meter dose inhaler through endotracheal tube, or if it is feasible, then you nebulize the patient with salbutamol. If the first line doesn't work, then you jump to second line, which is short-acting muscarinic antagonist like apratropium bromide. It is also given either by meter dose inhaler through endotracheal tube, or you can nebulize the patient with apratropium bromide if the time is favorable. Now, after giving propofol and bronchodilator, the bronchospasm does not break, then this is called refractory bronchospasm. Now, you have to jump to some other group of medicines like epinephrine at the dose of 10 to 12 microgram intravenously in the form of single bolus, Or you can give magnesium sulfate 2 milligram intravenously over 20 minutes. Or still it doesn't work, then you can add ketamine at the dose of 0.5 to 1 milligram per kg intravenously. To prevent recurrence, injection hydrocortisone is given at the dose of 100 to 200 milligram. Now, there are some complications associated with anesthetic agents like hypoxia due to communication failure, like you have ordered the staff or nurse to inject a drug, but a higher dose is being injected as compared to a normal dose. Or there is equipment failure, for example, the embo bag does not work, or oxygen supply is not proper, or there's operation obstruction or coexisting disease like COPD or asthma, which could not be identified during history of the patient. So now the symptoms are the adult patient will have tachycardia, which ultimately leads to cardiac arrest, and children will have bradycardia, which ultimately leads to cardiac arrest. The management is that you give 100% supplemental oxygen with embo bag mask. You can give continuous positive airway pressure. You can perform jaw thrust or Laurent's maneuver to prevent backfall of the tongue. Clear the airway by suctioning, and then you can add some drugs for conservative management like aminophylline, methylprednisolone, and salbutamol. So during the anesthesia and during operation, as a side effect of anesthetic agent, it can be hypothermia. Hypothermia is defined when the body temperature is less than 96 Fahrenheit or less than 35.5 Celsius. It can occur because of alteration of hypothalamus function by anesthetic agent, or it can be caused by vasodilation, which is a side effect of anesthetic agent, and heat is lost due to vasodilation. Or cold IV fluid is given as infusion. And there can also be hyperthermia. Hyperthermia can occur because of drug allergy, sepsis, thyroid storm due to uncontrolled hyperthyroidism patient, malignant hyperthermia. We will discuss about these in detail in our coming lectures, and pheochromocytoma, which is malignancy of adrenal gland. Now, there are some post-operative immediate complications like aspiration, hypoxia, hypercarbia, means partial pressure of carbon dioxide in the blood is more than 40 millimeter of mercury, hypo or hyperglycemia, hypotension, and some patient may experience hiccup. That is because of vagal stimulation. So, for relaxation of diaphragm, we give metoclopramide. And there are some delayed complication which is caused due to iatrogenic injury caused when endotracheal tube is passed, like hoarseness, sore throat, cough, tracheitis, tracheal stenosis. Thank you so much for watching this long session till the end. I truly appreciate your dedication. Make sure you check out the other 6 parts of this course on clinical anesthesiology and pain management. And if you want easy, well-organized notes for this lecture, you can follow me on the Udemy and download them there. Keep learning, and I will see you in the next video.